Let's briefly look at barrier end feel. The use of HVT requires engaging the barrier. The final activating force is carried out by the operator. The term barrier may be misleading if it is interpreted as a rigid obstacle to overcome with a push. As the joint reaches the barrier, restraints in the form of tight muscle and fascia serve to inhibit motion. We are pulling against restraints as opposed to some anatomic structure. For HVT to be effective, the barrier must feel solid. If the barrier feels rubbery, thrust techniques may be ineffective and may possibly damage tissue. Experienced osteopaths develop skills to engage the barrier quickly. They sense how the tissues are responding to how the force is being applied and make subtle alterations in the direction of force to effectively engage the barrier. Being able to engage the barrier with accuracy and confidence is a skill acquired with practice and experience. We are now going to discuss the accumulation of force. With a proper diagnosis, initial positioning engages the barrier. In the spinal area, the reference is a vertebral unit, two bones and the joint connections between them. Force is applied to the superior vertebral unit, which will meet forces applied to the inferior vertebral unit at the restricted joint. Depending upon the technique, force may be applied at one site. The opposing counterforce is resistance of inertia of body mass or resistance of the couch. In all cases, the force is directed at the restriction. Specificity of technique is a measure of how accurately the force accumulates at the restriction. To conclude, the principles of HVT are to identify motion restrictions of somatic dysfunction, to engage the barrier, apply the activating force, which is the high velocity, low amplitude thrust, and finally to re-evaluate the improved range of motion.